this lecture is a little bit different from the others because that will be the kind of pathway from uh, discovery of a radio tracer to using it in our research. And the idea is now really to go from the radiochemistry to the proof of concept in preclinical imaging, and then using human imaging for the kind of research we would like to perform. And so that's really there that the full platform of a neuroimaging center is fully used and must be fully equipped as well. So that, for example, you need certainly to have a GMP radiosynthesis, since you need to have a radio tracer that you know very well, and all the adequation are there to use it in human. And we will try to follow different steps in order to get such kind of radio tracer. So again, of course, we will discuss positron emission tomography. We might certainly go to SPECT as well and other, but we'll concentrate on an example which was used for positron emission tomography. And we'll discuss a little bit of the lower line with normalized scans, just explaining why this can be important. So I need to make the first pre-declaration of interest I had, because the marker we've been using, we designed that with UCB Pharma, and that was in a public-private partnership. And certainly, I need to tell that they say all the possibilities and all the chemistry that was coming from UCB was of great help in this kind of research. So if you remember, the biological model of Alzheimer's disease we've been discussing some weeks ago is just telling you that probably the pathology itself of the disease is coming to abnormal proteins and abnormal processing of proteins, and probably amyloid should be first, and very quickly then after might come tau, and again probably soluble first, because the oligomers would be much more dangerous for our neurons and synapses. But we think that synaptopathy might be very early as well, and that finally what the oligomers and abnormal oligomers of amyloid and tau are doing is above all making perturbation of the synapses, and so synaptopathy. And this was clearly our main hypothesis in that kind of research. And if you go back to the pathological hypothesis, certainly what we can see on the right of our picture is amyloid beta pathology, tau pathology, but all that is finally leading to a neuronal injury and pathology. So if we just have abnormal proteins that will not disturb the brain networks, we do not have a real pathology. And so we indeed, if you remember, have got very elderly people who never complain of their memory, or certainly not of cognitive decline, but they do have a lot of amyloid in the brain. So amyloid per se is not sufficient to determine and cause a decline of cognition. So there is a need for brain networks to be disturbed. And so we think that this disturbance is coming from a synaptopathy disconnection of the synapses between the neurons. And for looking at that, there were effectively two kind of remarks interesting in the literature. The first one just telling that the amyloid hypothesis is nice, but it's not sufficient. We knew that, and mainly that was to tell that there are some topathies that are important. But another kind of remark was quite interesting, telling that in groups and wide population, wide group of wide samples of patients, there may be some amyloid first biomarker profile, but sometimes neurodegeneration is coming first as well in preclinical Alzheimer's, so in very early phases. So we need to understand which is the exact sequences and time sequences of the event, and for that we need biomarker for each of those events. And this is what was made possible with markers for the synaptic vesicle 2A protein. So on your left, you've got a vesicle, synaptic vesicle, with a lot of proteins, and SV2A is only one of those. But the interest is that this protein is very ubiquitous in the brain. So if you remember for the previous presentation, we had a lot of neurotransmission system, and we know that the cholinergic system is going preferentially to some region of the brain. That's true for serotonin, that's true for dopamine. But what we would like to know is a kind of global abnormality, and to follow and mark and biomark a global abnormality, then we need to have a marker of synapses everywhere in the brain. And that's what's possible with SV2A. Now, why was UCB Pharma interested in SV2A? That's because they've got one of their most important anti-epileptic drug, levetiracetam, which effectively has been shown to exert an effect and bind to SV2A protein. So clearly their main interest was first to try to go further in the understanding of the anti-epileptic treatment, but with the same kind of radio tracer, it's then possible to imagine looking at different kind of pathologies, and those pathology where we've got disconnection. And that effectively the starting point of that research. And another point of interest has been that indeed levetiracetam, apart from its anti-epileptic properties, have been used in animal model, rodents model of Alzheimer's, and this group has shown that the administration of quasi-normal dose of levetiracetam was improving the situation in Alzheimer's, which means suppressing a dysfunction of the neural network and reversing a synaptic deficit. And so because that has been shown in animals, it was extremely important for us to try to get that kind of biomarker for our human research as well. So in fact, there has been different kind of radiopharmaceuticals now targeting SV2A proteins. The first one has been an 11-carbon UCBA compound. There is another 11C-carbon UCBJ, which is very well used and has been published in great journals. And what we've been working with is 18-fluorine UCBH. So remember that we in Liège are very keen of using 18-fluorine because of a longer half-life, 2 hours, which means that we can make several studies with the same batch, and we can try to design multi-center studies. To be fair, there are new other kind of ligands, not directly linked to the UCB kern, but for those kinds are all the kind of difficulties for using them right now in human. So what I will do is to concentrate on the story about 18-fluorine UCBH. And so the first point has been to make a radiochemistry, and that was effectively a success. So you can see here where the 18-fluorine has been put, and that chemistry has been optimized and published, so that now we can say that we can use this kind of molecule. And what you first want to see with the kind of molecule is a brain distribution. So what you want is to be able to make an injection, and normally an intravenous injection, because that's what will happen in nuclear medicine. And you need your drug to cross the blood-brain barrier, which is not always that evident. And so different kinds of markers, for example, just do not cross the blood-brain barrier effectively, or there is a too low percentage entering the brain. And then you want your biomarker to bind to a kind of receptor, whatever it is, binding site, and stay a little bit, because the other difficulty would be that the binding is too weak, so that the drug is extremely rapidly washed out the brain, so that you cannot see anything in the brain. And so that's what has happened in some kind of compounds we've been trying, but hopefully this one, UCBH, was giving in animal a very nice picture. You can see here in the frontal view, so you are just looking at the front, in front of the animal, and you see one hemisphere, the other one, and a good concentration, good uptake here. Here is the lateral view of the brain, and you can see there is something in the cord, spinal cord as well. Here, this is what you can see from both above and beneath, and effectively. So the idea is clearly there is an important uptake in the brain for our compound. Now, the second step, when you see that you can effectively have a drug entering, is making time activity curves. So this is exactly what you see here in blue. You've got your time in seconds. You've got the activity, which is measured in becquerel per milliliters of brain. And in blue, you can see that when you inject the drug in intravenously, you've got a relatively rapid increase in the brain, and then a progressive decrease, washout of the binding, which is going on over time. But what you want to show is that effectively The binding is clearly on the side you've got in mind. Because you might, for example, have a binding in the lipid, the white matter of the brain, which means that in that condition you are not able to measure any kind of density of receptors because you are measuring another kind of binding. And for that, in that case, we made a displacement, which means that a few minutes after injecting the radio tracer, we've been injecting what we call the cold radio tracer, which make competition with our radio marker. And you see the competition because since the actual quantity of the cold substance is greater than the quantity and the little quantity of our radio tracer, you see that we can displace our radio tracer over time with that kind of injection. So this is one of the first demonstrations that effectively there is a displacement with a drug competing. Then you can also show that if you've got a drug which is not competing, you shouldn't see anything. And in that case, if you see something, again, that might be a kind of argument to tell that your radio tracer might be binding to two different kind of receptors, for example. So far, so good. And then, because it was acceptable in preclinical imaging, we had to demonstrate that we could use a tracer in human. And so that was a first time in human study where what you wish is to get dosimetry. Because as you know, when we are using radioactivity, there are very precise rules of what you could use for research, what you could use for medical imaging, which is quite different of what you could use for radiotherapy, for example. So here with positron emission tomography, we are first using microdose. Microdose means that the specific activity you inject is very high. So a high concentration of your radio tracer and very low concentration of your cold molecule. So no kind of medical action of a drug, because that's not a normal dose, that's a microdose. And then you want to see where your radio tracer is distributed in the brain, where the radioactivity is maintained, and how many times it is maintained in order to know which is the dose received by the body. And so this is a kind of a publication we made. So hopefully in the human brain, there is effectively an accumulation of the tracer. But then we've got an accumulation which is non-negligible in the liver. There is an accumulation in the gut. But the most important accumulation is here in the bladder. So taking that into account and making a kind of a calculation, we could see that the effective total body dose was relatively low. And because we decided to inject a relatively low dose of the tracer, we can say that for each exam, our participant will have roughly 3 millisieverts as the effective total body dose. Moreover, because we know that the activity is concentrating in the bladder, the recommendation is clearly for people to drink a lot so that they will wash their bladder and eliminate as much as possible of the activity which is there in the bladder, so decrease the risk of local radioactive bat evolution. So, having that in mind, a very interesting study which was done there with UCBJ by our colleagues of Yale was to see what's happening in the monkey. And so they had here the magnetic resonance of one of their monkey. They injected the drug to CSV2A protein and the distribution, which is here again ubiquitous in this monkey. They've been quantifying and measuring the activity in the standard uptake value, which means that you kind of standardize the activity by the dose you inject and the total body of the monkey, so that you measure an activity per milligram or gram of brain, and you standardize that on the activity that you've been injecting and the global body, so that they could make a full modelization. You will see that with their measure of positron, and then when the animal was dead, they could make a real calculation in the brain of the number of binding sites, the number of synapses. And they've seen that there is a very good correlation between what is measured with positron emission tomography and what is measured post-mortem in the same regions of the brain. So again, that was an extremely interesting demonstration of the usefulness of the biomarker to measure something which exactly corresponds to proteins in the brain. After that, one of the possible problems with a radio tracer is that, as you've seen, you inject in the intravenously. Certainly it's going to the brain, but it's going as well to other organs. So you may be very interested in the other organs, but when, for example, our radio tracer is going to the liver, it's metabolized. So what you wish to know is what's happening with the metabolites, because over time, you may, for example, imagine that one of your important metabolites would be entering the brain, so that finally, what you're going to measure over time would not be the actual uptake and binding to your specific protein of interest, but might be a mixture of what is called the specific binding and a non-specific binding of a metabolite to all the sites. So we've been looking for metabolites with the most important one here. So we've been labeling this important oxide, and we've been demonstrating that by using purely that metabolite, there is no accumulation at all in the brain. So it's just remaining in the blood, in the plasma, so that it's not possible to get blood samples, make the difference between blood and plasma, and then make a measurement of our tracer and make a measurement of the metabolites over time just looking at what we are interested in, which is what is exactly the fate of our radio tracer over time in the blood, corresponding to the evolution of its accumulation and washout from the brain. And so, with all that, we had the opportunity to make a first picture of SV2A proteins, so kind of proxy of synaptic density in the brain. So what was extremely interesting for us was, for example, to demonstrate this part of the inferior temporal and medial temporal cortex, because those regions are not very well seen by FDG PET. In those regions, there is a high variability of the uptake, while here, with this tracer, it's clearly a part of the brain which is very well seen. Another part, if you remember the previous lecture, is a posterior cingulate, and the posterior cingulate part of a memory network is extremely important for us because that's a region which is very early impaired in Alzheimer's disease. So this was a demonstration that effectively we could see very important regions of the brain with that radio tracer. So now what we obtained was time activity curves, the TACs, now in the human brain. So again, you've got the time in minutes, and here you've got in different regions of the brain. You take a region of interest where you are interested to see what could happen. And again, you see after bolus injection that there is a rapid accumulation in the brain. And then after a short time of plateau, there is a progressive decline and washout over time. And this is allowing you to make a kind of modelization of what's entering over time, what's leaving over time, and finally what's binding in the brain. To get that, you will have a modelization. So this modelization, so having a dynamic acquisition over time of activity, which is giving you a time activity curve, which can be seen here with the squares. Then you enter what will be an activity in the plasma, and that's what will happen. Your radio tracer is coming in the artery. In the brain arteries, there is then a passage, so crossing of the blood-brain barrier to a free compartment. And from that free compartment, where you might have non-specific binding, you go into your specific compartment. And that's what you are interested in, because your specific compartment is effectively the protein of interest. But if we say, if there is effectively a binding to, there is as well a washout, and this part of the arrow is showing when the radio tracer is leaving your specific compartment to go into free, and possibly to go back into the circulation, the cerebral blood flow. And having that kind of model in order to determine what's effectively going on, you will get a part of your signal which will be free and non-specific, and then a part of it which will be a specific binding, and that's what you want to get with modelization. So we want then to have a full modelization. First, you need to use arterial blood sampling. Why do you want to use arterial blood sampling? Well, just because the arteries, the brain arteries, are uh, concentrating your radio tracer, and that's from that arteries that it's leaving the artery to go into the brain. And what is closer to the activity in your brain is the activity you will obtain in your arm. So you put an arterial catheter in one of the artery of the arm, and you've got a proxy of what's going on in the brain. So with that, it's possible to demonstrate now in the blood, in the plasma, what is the evolution of your free, unchanged plasma fraction. And you see that first you've got a 100% of your radio tracer, but over time, because of the metabolites, your free fraction, your unchanged fraction, is decreasing over time. And it's possible to see with a number of participants that finally the variation over time of that decrease is not that important over time. And so you can use that proportion of unchanged in order to correct your arterial input curve, because you do not want to count in the artery the activity which is coming from metabolites. So you just use the activity coming from the unchanged radio tracer. Then it's possible to obtain different kinds of models. This is one kind of model. I'm not going through the details of it, but having your brain activity, having your plasma activity corrected for your free fraction, it's possible to obtain a total volume of distribution, so which will be both your free and your specific compartment, and you see one global measure of which is the kind of uptake of your drug in the regions of interest in your brain. And so you effectively have got a modelization. But this modelization is with arterial cannula. And hopefully you wouldn't like every kind of participant or patient to get an arterial cannula. So what can we do? So what we could do first was to demonstrate that the pure activity that you measure in the whole blood and that you measure in the plasma are very similar. This is not always the case. That was the case for this kind of tracer, but that was lucky, because that means that finally you can trust into whole blood to be a very good proxy of plasma, so that if you just apply your curve for unchanged free fraction, then the one you apply to plasma can be applied to whole blood. Why is it of interest? Well, this is because with positron emission tomography, not only is the brain in the field of view of your camera, but the carotid artery is also in the field of your camera. So this is the overlapping of the MRI, and this is what your carotid artery are. And then it's possible to put regions of interest of your carotid artery on the PET image. So finally, with a positron emission tomography dynamic acquisition, you obtain time activity points not only for regions of the brain, but also for the activity in your carotid artery, which is your arterial activity going into the brain. And so you obtain an image-derived arterial activity, arterial carotid activity. And then, if you can demonstrate that making a gold standard arterial sampling is relatively similar than having a image-derived activity, you could avoid taking arterial cannula for your patients. So that's what we did, and effectively with the measure, we demonstrated that with the image-derived input function, so your input which is coming from pseudo blood, and with your measured input function with arterial cannula, you finally obtain roughly the same kind of information when you measure your total volume of distribution of the tracer. So with those demonstrations, it was then possible to obtain for our first volunteers a map of the distribution of the synaptic density corresponding to the density of SV2A protein in the brain, where you see again that in this cingulate cortex, for example, there is an important accumulation, which is the most important one here in red, and then that you've got all the region with quite less important activity, and all that now can be quantified. In a first little a group, so only 2 older people and 2 young participants, we took several regions of interest. For example, here, the centrum semiovale, that's white matter in the brain, where normally you wouldn't like to see too much of activity, but anyway, there is a little one, partly because there is an overlapping between the gray matter and the white matter, partly possibly because there is a non-specific binding, and so this is a first a difference we obtain with a little bit more activity everywhere in the young than in the older people. But for all the other regions anyway, there is an activity. So again, you can see that this kind of protein, which is the SV2A protein, is effectively ubiquitous in the brain, even in if some regions have got a little bit more activity, in regions of interest such like the hippocampus, para-hippocampus, we've got, well, relatively good activity, good contrast that is interesting for our studies. So each time it's extremely important to tell that such a development is clearly a development of multiple teams. So we had the team for organic synthesis and radio synthesis. We had our UCB partners for providing the cold drug. We had the preclinical imaging, we had the clinical imaging. So all those people have been involved in such work. So how could we use that? I already showed you that apart from making first studies in normal control people with that extremely interesting distribution in the medial temporal and inferior temporal cortex, we could see in Alzheimer's disease that there is effectively a decrease of activity in the medial temporal cortex. Now that decrease of activity, you wish and you need to measure it and to try to find a statistical difference between structures. And in order to do that, we go back to positron emission tomography, because as you may understand, when you put your participant in the tomograph, you try to put the participant in the middle of the field of view, but it's extremely difficult to be sure that they will be exactly all in the same position. So what you do is that after you obtain your 3D volume, you then need to rely on templates and on a marking, anatomical marking, and there have been a design for making the same kind of mark and neuroanatomical mark in every kind of the brain, so that you can reorient the brain, so that each and every brain is oriented in the same direction. Then the second point is that you also will modify and wrap your brain in order to have not only big brain or small size brain, but to try to have all the brain in the same dimension by trying to map your brain on a template. And with that possibility, you've got a wide amount of 3D image of the distribution and the measured distribution of your tracer in a population of control compared to a population of patients. Then you can make statistical analysis, and by doing so, on an MRI template, you can see that for Alzheimer, compared to control, the decrease of activity was perfectly in the hippocampus. So again, which is quite normal, since the first pathology of Alzheimer is in the entorhinal cortex, and the neurons, the body of the neurons, are sending axons with axonal ending and synapses in the hippocampus. And so that's perfectly normal. That's where we find the most important decrease and loss of synaptic density. Another point of interest, so it's just to demonstrate that we can quantify this in control and in a patient. Well, clearly there is a wide standard error, so you need to take that into account, but this is anyway possible to demonstrate and quantify, and we obtained a 28% decrease of hippocampal binding in Alzheimer. That was quite interesting because all the colleagues using UCBJ PET showed that in Alzheimer's there was effectively a decrease of the binding as well in the hippocampus. So this is in Alzheimer, mild cases of Alzheimer again, and so just a demonstration of the same kind of result with the two actual tracer for SV2A. So clearly a point of interest is to tell, okay, but we know for a long time that FDG PET has kind of reflecting synaptic activity. But what we observe when we look at the kind of most important decrease of glucose uptake in the brain of patients with Alzheimer, which is here in the cingulate cortex, but not very much in the medial temporal cortex, you see that with UCBJ and with UCBH indeed, the decrease of activity is much more in the medial cortex and a little as well in the cingulate cortex. So the point is that both tracers are not exactly showing the same, and that's what I've been discussing in the lecture on Alzheimer, telling that effectively glucose uptake is telling us a lot more than pure synaptic density, and that if we want to measure synaptic density, SV2A is a much better tracer and much more specific tracer. Then you can use the same kind of information to make correlation with what's happening in patients. And for example, here we can see in the hippocampus a correlation with what is called the unawareness of cognitive decline, which means, for example, that some patients and a lot of patients just do not realize that their memory impairment is important. They will recognize there is a little bit of something, but frequently they do not see which are the consequences of memory loss in the daily living. And that kind of synaptic density is telling us that there is effectively something happening there that do not allow them to completely understand what's happening with their cognition. And finally, I've been showing you already that our colleagues from KU Leuven have been using not only 11 carbon UCBJ, but also a tau tracer, and could wonderfully demonstrate that there is in Alzheimer's disease a correlation between the local tau deposition and the local pathology of the synapses. So again, which is telling us that in Alzheimer there is a relationship, and that we clearly want to go into the preclinical stages in order to understand a little bit more, which is the kind of sequencing of the event coming in Alzheimer's disease. And finally, just to remind you that it's possible to use a tracer not only for Alzheimer, but for frontotemporal dementia as well, and to see another kind of abnormality that can be seen in the medial temporal and the pole of the temporal cortex in that other kind of disease. So I will conclude here those different lectures just by, I hope, telling you that really molecular imaging and biomarkers are becoming more and more important to demonstrate what is the pathology of a lot of diseases. If you understand what is the pathology, try to find with multimodal and multiple markers, which is a sequences of events. When you know sequences of events, try to see if a drug, which you hope will modify the evolution of the disease, is effectively modifying as well the key molecular constituent or steps of your pathology, and so make a real follow-up. And moreover, you need to demonstrate that effectively what a drug is doing on your kind of a molecular pathway is related to something clinical and has got an importance, because in some cases we've seen that some drug can act on different biological pathway but do not effectively lead to important clinical differences, because the brain is complex and we might have different pathways coming into play for determining a clinical status. So I would like to thank you for your attention, again to thank all the collaborators which are working on that important topic and underline the importance of making multi-center studies for this kind of research to be sure that we confirm in multiple centers what we see in first in human studies. Thank you again.